How fast does glaucoma progress? Glaucoma is not a one-size-fits-all disease. Its course varies dramatically from person to person. Some patients' vision barely changes over decades, while others may slide from mild damage to legal blindness in just a few years, even with treatment. Knowing your place on this spectrum is crucial. It indicates how aggressively your doctor should treat you, how often you need checkups, and ultimately whether you'll keep useful vision for life or risk losing it. In short, the speed of your glaucoma's progression is the single most important piece of information in your care. This article reviews the hard data on glaucoma progression rates from major clinical studies and explains what factors influence individual risk, how doctors measure worsening, and what patients can do to slow the clock. Spectrum of glaucoma progression rates. There is no single answer to how fast does glaucoma progress. Rates vary enormously. Major studies show untreated glaucoma often worsens substantially over years. For example, in the Early Manifest Glaucoma Treatment (EMGT) trial, newly diagnosed open-angle glaucoma, untreated patients' visual fields declined at a median of -1.0 to -2.0 B per year in mean deviation (MD). Roughly 60% of untreated patients met clear, definite progression criteria within 6 years. When treated with pressure-lowering drops or laser, progression slowed but did not stop. In EMGT, treated eyes lost only about -0.5 dB year on average, and only 45% progressed in 6 years. Large clinical cohorts confirm huge variability. A Swedish practice survey found the mean perimetric decline was 0.88 dB year, median 0.62 year. But the range was broad. About 5.6% of patients lost more than -2.5 D per year. In practical terms, even a small loss of 0.5 dB year, half a tenth of normal visual sensitivity per year, adds up relentlessly over decades. For instance, a patient diagnosed at age 50 with a mild mean deviation of 3 dB could reach 18 dB, moderate to severe loss, by age 80 at 0.5 dB year. Conversely, someone losing 2.0 D per year, a fast rate, without treatment might hit 18 dB in only 7 or 8 years, a devastating slide. The Canadian Glaucoma Study, a large natural history series, likewise found that treated glaucoma often changes slowly on average, but with a long tail of fast progressors. The overall mean MD decline in treated patients was only about 0.05 D year, but the distribution was wide. In fact, the fastest 20% of patients in that study were losing more than 1.5 dB year despite therapy. These findings underscore that truly answering how fast is my glaucoma progressing requires personal data. Individual trajectories vary far more than averages. What do published studies tell us? Several landmark trials have quantified glaucoma progression rates in untreated and treated eyes. Understanding their findings grounds our understanding of fast versus slow disease. Early Manifest Glaucoma Treatment, EMGT. In this trial of newly diagnosed open-angle glaucoma patients, untreated control eyes had a median MD decline around -1.0 to 2.0 dB per year, and about 60% showed definite glaucoma progression within 6 years. Eyes treated with pressure lowering, initially betaxolol drops plus laser, declined about half as fast, roughly 0.5 dB per year on average. Treatment greatly reduced, but did not eliminate progression risk. In numerical terms, 62% of controls progressed versus 45% of treated eyes over 6 years. Note, Heil et al. 2002 JAMA Ophthalmology. Advanced Glaucoma Intervention Study, AGIS. This surgical study, patients with severe glaucoma, powerfully illustrated the benefit of maintaining consistently low IOP. Over 6+ years, eyes that always kept IOP 18mm Hg at every visit had essentially no net visual field loss, whereas eyes that occasionally spiked above 18mm Hg progressed measurably. In the AIS analysis, eyes consistently below 18mm Hg had mean progression near zero, but eyes with less stable control worsened by 0.6 units of visual field defect score more over several years. In plain terms, pressure spikes appear to drive nerve damage as much as average pressure. AIS Investigator Report, AMJ Opthal, 2000. Collaborative Normal Tension Glaucoma Study, CNTGS. In normal tension glaucoma, IOP never above normal range, untreated eyes still worsened significantly over time. In this landmark trial, 60% of untreated NTG eyes progressed by 5 years, compared to 80% survival, no progression, in the group with a 30% IOP reduction. In other words, lowering pressure by 30% halved the risk of field loss at 5 years. Importantly, even with treatment, some patients continued to deteriorate, showing that IOP lowering helps but doesn't cure NTG. United Kingdom Glaucoma Treatment Study, UKTS. This more recent trial, Glaucoma versus Placebo Drops, reported that almost 25% of medically treated glaucoma patients showed definite visual field progression within just 2 years. This reinforces that significant change can happen quickly in a substantial minority. Taken together, these studies prove 2 points. 1. Medical or surgical therapy significantly slows glaucoma, but can't stop it completely for everyone. And 2. Individual rates vary widely. In practice, mean MD declines in clinics range from near zero in well-controlled cases up to 0.5 dB per year or more in aggressive disease. From numbers to everyday vision. An MD, mean deviation, loss of 0.5 d year might sound tiny, but it accumulates relentlessly. Over 40 years, age 50 to 90, even NIA's 0.5 dB year is 20 dB total. MD is measured in decibels. dB, a logarithmic vision scale. 2 dB or minus 3 dB is mild field loss. Here 12 dB is commonly considered moderate loss, and 22 dB is around legal blindness. Thus, a patient who starts at 3 dB at age 50 and loses vision at 0.5 dB year could reach 18 dB, severe loss affecting daily function by age 80. By contrast, a very fast progressor losing 2.0 Ds per year without treatment could hit 18 dB in 7 to 8 years, a dramatic decline. A rule of thumb often used is to estimate years to blindness by dividing remaining field margin by the current loss rate. For example, if one eye has MD equal as 10 dB and is losing minus 1 dB per year, it has 10 years until reaching minus 20 dB near blindness in that eye. Of course, glaucoma rarely follows a perfectly straight line. Rates can accelerate with treatment failure or adherence lapses. But this calculation forces the abstract slope to become an understandable timeline. Importantly, the earlier ages matter most. Younger patients with decades of life ahead stand to lose more over their lifetime, even if their yearly slope is modest. A 40-year-old losing 0.5 dBs per year will ultimately lose far more vision than a newly diagnosed 80-year-old at the same rate, who may not live to severe blindness. Thus, even slow progression can be catastrophic for the young. Conversely, in an 85-year-old with early disease, the regression analysis might show 0.6 dB per year, but the doctor might decide not to intensify treatment if their life expectancy is short, since the patient is unlikely to hit functional blindness before age-related decline. What factors influence progression speed? Intraocular pressure IOP is the single most powerful modifiable factor. Every 1 mm drop in long-term IOP lowers glaucoma progression risk by roughly 10 to 15%. In EMGT, a 25% pressure reduction, 5 mm/grams, cut the 6-year progression rate from 62% to 45%. Lowering IOP as much as safely possible is the cornerstone of treatment. Equally important is keeping it low and stable. Research suggests that even brief IOP spikes may stress the optic nerve and speed damage. The AS study showed that eyes kept under 18 mm/grams every visit had almost no field loss, whereas tiny excursions above 18 mm/grams correlated with faster visual field decline. This hints that the nerve might suffer a bit each time the pressure gun's above its comfort zone, similar to metal fatigue from repeated stress. Other key factors determining individual progression risk include baseline disease severity. Patients diagnosed at an advanced stage tend to worsen faster. They have few remaining healthy nerve fibers, residual functional reserve, so each additional fiber lost causes a proportionally larger jump in visual field loss. Also, extensive damage may change the eye's biomechanics, e.g. in altering the lamina cribrosa, in a way that makes it easier for IOP stress to cause further injury. In one study, eyes with more visual field loss at baseline actually had slower per-year MD decline due to floor effects. But clinically, we know advanced eyes reach disability sooner if they continue to progress. Age at diagnosis. Older patients generally show faster progression. Aging optic nerves are thought to have less resilient retinal ganglion cells, poorer blood flow, and diminished mitochondrial energy, factors that compound glaucoma's damage. Studies confirm older age is associated with steeper MD slopes. However, note the flip side. Younger patients may progress more slowly annually, but their longer life ahead means more total vision may be lost over time. Race ethnicity. Glaucoma affects populations unequally. People of African descent have higher glaucoma prevalence, an earlier onset, and historically higher rates of blindness from glaucoma. Part of this appears genetic, e.g., some susceptibilities in optic nerve structure, and part socioeconomic, later diagnosis and variable access to care. Recent long-term studies like ADES, which provided equal care to Black and white patients, found similar progression rates when treatment was equal. However, in general clinical observations, Black patients often present earlier and progress faster, contributing disproportionately to glaucoma blindness. Other groups, e.g., individuals of East Asian descent, also have higher rates of normal tension glaucoma. It's crucial for providers to be aware of these differences so at-risk patients can be monitored closely. Optic disc hemorrhages. One of the strongest warning signs of impending decline is seeing a disc hemorrhage on exam. Numerous studies show that eyes with a disc hemorrhage are many times more likely to worsen thereafter. For example, one classic study found 63% of eyes with a documented disc hemorrhage progressed on fields, compared to only 24% of matched controls without a hemorrhage. In practical terms, a hemorrhage signals that the disease is active, hotspot, and you should assume the patient's glaucoma is accelerating. Clinicians typically respond to a new hemorrhage by reassessing treatment, often lowering the target IOP further or adding therapy, even if the field loss so far seems minimal. Central corneal thickness, CCT. A thinner cornea independently predicts faster glaucoma progression. Originally noted in the ocular hypertension treatment study and other trials, eyes with thin CCT, e.g. 550 mm, have higher risk of developing glaucoma, and once glaucomatous, tend to seem to worsen more quickly. Some of this is attributable to measurement error. Thin corneas make the true IOP slightly higher than it reads, but there is likely a structural component. Thin corneas often correlate with thinner lamina cribrosa, or more elastic connective tissue, which may be more susceptible to pressure damage. In practice, patients with thin CCT are treated more aggressively. Blood pressure and perfusion. The optic nerve is very sensitive to blood flow. Low ocular perfusion pressure, calculated from IOP and blood pressure, is linked to faster glaucoma damage. This is especially critical at night. Patients who naturally have significant nocturnal blood pressure drops, often due to hypertension meds taken at night or an overdipping pattern, are at higher risk of progression. Diastolic hypotension and sleep apnea, which cause oxygen cholesterol issues that impair optic nerve perfusion, also correlate with faster field loss. In normal tension glaucoma in particular, vascular factors seem to play a big role. So doctors often ensure blood pressure isn't pushed too low at night and treat sleep apnea or other circulation issues as part of glaucoma care. Systemic vascular health. Diabetes, sleep apnea, migraine, and other conditions affecting vascular health can worsen glaucoma. For instance, obstructive sleep apnea with repeated nighttime oxygen drops has been associated with more rapid glaucoma damage. While lowering IOP is paramount, optimizing overall circulation, good blood pressure control without overdosing BP meds, cholesterol management, aerobic exercise to improve blood flow is considered part of a comprehensive plan. Myopia, nearsightedness. Myopic eyes, especially high myopes, appear more vulnerable. An elongated eyeball causes stretches and thinning of retinal tissue and the lamina cribrosa. Highly myopic patients may develop glaucoma at a younger age and seem to lose vision faster. The optic nerve head anatomy is also different, often tilted or with larger parapapillary atrophy, complicating diagnosis and follow-up. Clinicians keep a close watch on myopic glaucoma patients for progression. Genetics. Many genetic variations influence not only glaucoma risk but progression. Mutations in MYOC, OPTN, TBK1, and other genes have been linked to more aggressive disease. Likewise, common polymorphisms, e.g. in 6 or CDKN2B-AS1, can tilt the speed of damage. While this is a burgeoning field, emerging polygenic risk scores may in the future flag who is likely to be a fast progressor from the moment of diagnosis. At present, genetics play more of a supportive than definitive role in daily clinical decisions, but your doctor may consider family history and any known syndromic associations when judging risk. How progression is measured. In practice, ophthalmologists track glaucoma with structural imaging and functional testing. The gold standard for monitoring is automated perimetry, visual field testing, which measures the patient's visual sensitivity in each area of field. Progression is usually quantified by looking at trends or by detecting new defects. Trend analysis, slope measurement. Here, the doctor calculates the slope of mean deviation, MD, over time, often using linear regression. A negative slope, in dB year, quantifies the speed of decline. Detecting a reliable slope requires enough tests, typically at least 5 to 6 reliable visual fields over a 2 to 3 year span before the statistical trend becomes confident. That means early in disease, clinicians only have a rough guess of how fast you're losing vision. With more data points over time, the MD slope becomes a precise personal rate of change. Studies show average rates in treated glaucoma range broadly, but anything approaching 91.0 dB year is considered fast. For comparison, normal aging alone causes about 0.06 dBs per year loss. Event-based analysis, guided progression analysis. Many VF machines have an algorithm, like guided progression analysis, that flags individual points in the field that worsen compared to baseline on repeated tests. If, say, 3 points in the same area deteriorate on 2 consecutive tests, the software will alert possible progression. This method can detect change sooner than a linear trend, but at the cost of more false alarms from test variability. It's useful to alert the doctor early, but positive prompts must be confirmed, often by repeat testing in 6 months, so as not to overtreat normal fluctuations. Optical coherence tomography, OCT imaging. OCT gives structural measurements of the optic nerve and retinal nerve fiber layer, RNFL. Doctors monitor thinning of the RNFL or ganglion cell layer. OCT can sometimes detect a structural change before a visual field change is seen, pre-perimetric progression. OCT measurements have less day-to-day variability than fields, making slow changes easier to confirm. However, OCT has a floor effect. Once the tissue is very thin, advanced disease, the scan can't tell if it thins further. It just bottoms out. Ironically, that's when you most need to know if the patient is still losing vision. In practice, doctors use both OCT and fields. Early on, a small OCT thinning may warn of trouble, while in advanced glaucoma, small changes on the field, especially centrally, become more important because OCT is maxed out. This structure-function dissociation, where structural loss may precede field loss in early glaucoma, and functional loss may lag structure in mild disease, but then continue after structure bottoms out, means each case must be assessed with all data in mind. Artificial intelligence and big data. Cutting-edge tools are emerging where AI algorithms take a patient's pressure log, multiple OCT measures, multiple visual field slopes, disc photos for hemorrhages, corneal thickness, systemic factors, etc., and compute a personalized risk of progression over 5 to 10 years. These eyes in the cloud can sometimes predict who will lose sight better than one doctor's estimation. While still in development, they underscore that the future of glaucoma care will be increasingly data-driven and tailored. When does progression warrant action? Not every tiny change in the numbers means panic. Clinicians distinguish statistically significant, detectable progression from clinically significant progression. The key question is the field getting worse fast enough to threaten your vision in your lifetime? Experts commonly use benchmarks for mean deviation loss rates, dB per year. Roughly, fast progression, worse than a 1.0 D year. This rate is usually considered too fast. Most doctors would take urgent action, lower IOP target, consider surgery if a patient is losing 1 D per year. Moderate progression, about 0.5 to 1.0 dB per year. This merits a serious rethink of therapy. The doctor will consider whether your current target pressure is low enough and whether dropping it further is needed. Slow progression, less than 0.5 dBs per year. For many elderly patients with early damage, a slope in this range might be acceptable given treatment risks. After all, the benefits of more medication or surgery must outweigh the risks. But note, for a young patient, even 0.4 dB per year could add up over decades, so context is everything. Other considerations modify these thresholds. One useful concept is years to blindness. If modest progression will consume all your remaining visual function by age 85, clinicians will likely treat aggressively, even if the rate seems moderate. Conversely, if an 80-year-old has mild glaucoma with a slope of 0.6 dB per year, but only 5 to 7 years life expectancy, the doctor may be more conservative. In general, many specialists use 1 point per year MD as a trigger for fast needing aggressive therapy, minus 0.5 to minus 1.0 as moderate, and under 0.5 as slow for older patients. Importantly, these numbers came from expert opinion and retrospective studies, not hard and fast rules. Saunders et al. Note that fewer than 20% of treated eyes progress at rates likely to affect quality of life. But for that subset, action is urgent. One must remember progress rates can change. If you start to progress faster than before, or if the damage encroaches on the center of vision, the calculus changes. Small losses in the central field, which affect reading and face recognition, may be more consequential than larger losses in peripheral field. Also, rates need not be linear. A patient might be stable for a few years and then suddenly worsen due to loss of a resistant group of nerve fibers, medication noncompliance, steroid use, or another factor. Hence, ongoing vigilance is required. The period right after diagnosis is a window of opportunity. Controlling fast progression early protects many nerve cells while they're still there. Later, once many fibers are gone, even the same pressure control leaves fewer to salvage. Subtypes. Does type of glaucoma matter? Different forms of glaucoma have different natural histories. Primary open-angle glaucoma, OAG, the most common type in Western countries. It usually progresses over years to decades. Person-to-person variation is huge, influenced by all the factors above. Many patients under treatment progress very slowly, but a significant minority decline quickly. POAG in young people can be surprisingly aggressive, while in older patients with mild disease, it may crawl along. Normal tension glaucoma, NTG. Here pressures are normal, 21 mmHg, but damage occurs. NTG often shows slower absolute MD decline than high-pressure disease, yet in practice it can be harder to halt. Because we don't have high IOP to blame, clinicians suspect blood flow problems or other factors. Studies show NTG still leads some patients to blindness over decades, especially if other risk factors, e.g., disc hemorrhages, sleep apnea, are present. Lowering IOP by 30% does help in NTG, but not as predictably as in POAG, since non-pressure factors still lurk. Acute angle closure glaucoma. An acute attack, sudden blockage, can destroy vision in hours if not undone. By the time the eye is watered or eroded after an attack, enormous pressure spikes can leave severe field loss. However, if treated emergently, laser or surgery, and prevented from happening again, long-term outlook improves greatly. Once the angle is opened, e.g. with iridotomy, many such eyes stabilize like open-angle glaucoma. Chronic angle closure glaucoma, where the blockage develops slowly or recurrently, can worsen insidiously at rates similar to or faster than POAG, unless the angle damage is relieved. Neovascular glaucoma. By far the most fulminant. In eyes with severe retinal ischemia, like proliferative diabetic retinopathy, new abnormal vessels grow in the angle, causing incredibly high and refractory IOP. Without rapid control of the underlying ischemia and pressure, vision can be lost in weeks to months. This form is essentially on the extreme end of fast progression. Optic nerve destruction may be nearly complete very quickly if untreated. Pseudoexfoliation. Glaucoma. This is an open-angle subtype with flaky material clogging the drain. It tends to be aggressive, higher IOP fluctuations, more often poor response to drops, and rapid damage. Pseudoexfoliation eyes often progress faster than typical POAG and account for a lot of glaucoma blindness in many populations. Surgery may be needed sooner in these patients. Pigmentary glaucoma, seen in young myopic patients where iris pigment disperses and clogs the angle. It can cause significant early damage. Interestingly, because pigment dispersion often decreases with age, some patients stabilize later on. But the young case makes it a dangerous form. Congenital and juvenile glaucoma. In children and teens, glaucoma tends to be very aggressive. Kids' eyes may tolerate pressure differently, but untreated glaucoma in youth absolutely leads to severe vision loss over many years. Progression is compounded by the challenge of ensuring perfect adherence to drops appointments in childhood. These patients need very close monitoring and often surgical therapy early. turning data into action, your progression management plan. Ultimately, statistics guide personalized care. Here's how to turn knowledge of progression risk into a concrete plan. Establish your baseline and rate early. When first diagnosed, your ophthalmologist should get a solid baseline of fields and OCT scans. You'll then need regular follow-up fields, often every 3 to 6 months for active disease. It usually takes at least 5 reliable fields, often over 2-3 years, to confidently calculate your MD slope. Ask how many fields you've done and what the latest trend shows. Don't rely solely on vague comments. Many patients find it eye-opening to see their own printed visual field series or MD over time graph. If you suspect something has changed, you notice new blind spots, or your MD is drifting downward on paper, speak up. Early detection of acceleration is critical. Set appropriate monitoring intervals. The frequency of testing should match risk. A patient losing 1.0 Ds per year might need fields every 3 to 4 months. A stable, low-risk patient might be fine with yearly testing. Guidelines vary, but if your doctor isn't ordering fields often enough or refusing OCT, given your risk factors, ask why. If you have multiple risk factors, high IOP, headaches at night, thin cornea, African ancestry, etc., err on the side of closer monitoring. Know your target and be ready to act. You and your doctor should agree on a target IOP for you based on how fast you're progressing. For example, if you are on drops and still losing 1 dB a year, your target might be lowered further, perhaps adding another medication, switching to laser, or considering a microinvasive or traditional surgery. Many practices now use step-up protocols. If a patient's loss rate crosses 1 dB a year, surgery is strongly recommended. If you're 0.5 to 1.0, consider adding therapy. If then a 0.5, continue current plan. But ultimately, it's personalized. A young or monocular patient would have a lower tolerance for loss than an elderly patient with early disease. Be your own advocate. Patients should feel empowered to ask for copies of their visual field printouts, slope reports, and OCT thickness graphs. Study them if you can, or have someone help. Sometimes doctors do the math in their heads and only mention stable or a bit worse without nuance. Seeing the numbers can make it clear if action is needed. If you're uncertain, asking, "Am I progressing at a concerning rate?" is a valid question. Many clinics now even allow patients to review their test results between visits. Address modifiable risk factors. Beyond eye drops and surgery, lifestyle and systemic health count. Regular aerobic exercise, like walking, swimming, jogging, has been shown to lower IOP and improve ocular blood flow. While we lack definitive trials proving it slows glaucoma, the evidence suggests it can be helpful and has no downside. Optimize your blood pressure, not too high and not too low. If you or your cardiologist run low-dose blood pressure meds at night, discuss how that might affect your optic nerve perfusion. If you snore or have known sleep apnea, get it checked. CPAP or weight loss can improve nighttime oxygenation and may slow field loss. Control your blood sugar and cholesterol. Don't smoke. And eat a balanced diet rich in leafy greens and fish, which support vascular health. None of these acts like an IOP drop of 5 mmHg, but they tackle the non-pressure mechanisms of glaucoma damage and are worth doing. Consider neuroprotection. Researchers are investigating drugs that protect optic nerve cells beyond IOP lowering. Some eye doctors recommend supplements like vitamin B3, nicotinamide, which in a recent trial, 1 gram per day, slowed progression in some glaucoma patients. Citicoline, a brain energy supplement, has shown some promise in small studies for modestly improving field scores. While these are not yet standard worldwide medicine, asking about them is reasonable. Any such therapy should add to, not replace, proper IOP control. Prepare for changing therapies. If you are a fast progressor, know that you may ultimately need more aggressive treatment. That might mean laser trabeculoplasty or tube shunt surgery, particularly if maximum drop therapy isn't enough. Getting surgery done earlier rather than later in a steeply declining patient can preserve vision that drops alone might not save. Discuss with your doctor. Given my rate, at what point would you consider surgery? Stay informed about research. The good news is that glaucoma research is advancing. In coming years, we hope for better neuroprotective drugs, stem cell or gene therapies, and even devices that constantly monitor IOP or deliver drugs. But for these to help you, they need you to still have vision left. By keeping your disease as controlled as possible today, you give yourself a chance to benefit from tomorrow's breakthroughs. Ultimately, the battle against glaucoma is won or lost by management of progression. No one can guarantee your glaucoma will stop, but with diligent monitoring, timely interventions, and attention to every risk factor, you can maximize the years of useful vision you retain. Understand your personal progression rate, be an active participant in your care, and act on the data. This vigilance can make the difference between blindness and seeing the next new treatment on the horizon. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.